Good afternoon and thank you. I'll be presenting here on behalf of Max Essex, who couldn't be with us today. So basically, this is from the Botswana Combination Prevention Project. Just a background, we all are aware that the National Free ART program began in 2002 in Botswana. And for the study known as BCPP, this is a pair-matched community randomization trial in 30 villages in Botswana. And here I'm just reporting on the 20% of households randomly selected from all the study communities. Some of this may have been presented at CROI, you'll bear with us, but we do have a few updates. So basically this represents the study communities in Botswana. We'll appreciate that most of them are concentrated along the eastern and northeastern belt. That is really where most of the population is. We do have an outlier somewhere there in the northwest, represented by community 13. So the average community size at about 6,000 and the total population just about 181,000. And by eligibility criteria, we're looking at the age group 16 to 64, which represented about 105,000 participants. So based on our accruals enrolled into the 20% cohort, about 12,610 participants, of which 28.6% were HIV positive. By distribution, we see male to female in terms of ratio. Taking it to the first 90, 83.3% of the participants actually knew their HIV status. For the second 90, 87.4% were actually on ART. This was quite impressive in Botswana because the baseline of this is on a country where CD4 eligibility was at CD4 count of 350 or less, or a WHO staging of 3 or 4. Looking at the third 90, Botswana, since implementing the ART program, has been one of the very few African countries who adopted a viral load triaging system. So we have had viral load testing since 2002. And of those who were positive and on treatment, we recorded a 96.5% suppression rate. This was regardless of which line of therapy they were on, first, second, or third. And of that, by our national standard, our definition of a viral load failure, we use a 400 cutoff, unlike WHO at 1,000, even though from the labs, they report 400 for clinical purposes. But you will also appreciate here, for those with a documented viral load less than 400, actually it was less than 50 copies per ml. So progress towards the 90-90 goals. For the first 90, Botswana is at 83.3%. For the second at 72.8%, and the third at 70.2%. This really in line with the movement to treat all. Botswana started implementing Treat All June 3, 2016. We are fortunate in that we have a base for which we should be able to report in a year from here. So, the first question, we were wondering, we did say the average community size was 6,000, but we were wondering if this was really representative of the country. We did appreciate that in the peri-urban villages, we did have a lower prevalence, around 22.3%, and a lower number in terms of the first two 90s, versus the more rural villages, which had a higher prevalence of 31.3, but did better in terms of the first, second, and actually the third 90. So, does age and sex matter? We also did find out that the younger age was associated with a lower score for the first two 90s, and also male gender. From the survey participants, 10% had actually refused, and 9% were absent for various reasons from the communities, and a sensitivity analysis was done to account for the differences between the unenrolled and enrolled participants, if it would change the results. There we see, we used two. First, they used the national census statistics and also what was reported through the national program, and we did not observe any significant difference. So, likely transmitters, that is those with the highest viral load, representative of the population sampled. So here we will see a correlation between knowledge of HIV status and viral load, and hard to find men who were unaware of their status more likely to be transmitters of viral load. This just looks at viral loads that were recorded for those that were over 400, our national standard. And for those who were aware and unaware, we did appreciate that for some reason, those who were aware had lower viral loads. This just looks at the association between gender, age, high viral load, and knowledge of infection. That is the first 90. We do see here in terms of high viral loads, much more in males who were unaware. And I think the general trend is that the viral loads are higher in those who were unaware. So one question we've always asked ourselves in Botswana is, will the 90-90-90, will it be enough to reduce incidence targets by then? I mean, we're already reporting high numbers towards the 90-90, high coverage rates, high viral suppression rates. So where is it that Botswana may be missing it? Here just gives you over time the incidence as has been measured. In 2013, it was unadjusted, and we were looking at an incident rate of about 2.89% in 2008 and a 2.47 in 2013. And based on the current study, we are looking at estimates around 1.06%. So how low can this incident rate go? Is it possible? Is it realistic? Just based on what we're reporting now. So really, as we move on to treat all, this serves as a guide for us in Botswana on areas where we may need to focus to really decrease the incidence rates. So for us, in our setting, our future consideration should focus on men who are unaware of their status. And we also know Botswana's policy on treating non-citizens and all that. That may be an area also that we need to focus on. And other targeted subpopulations like the young and so forth. So in conclusion, Botswana is indeed close to achieving the target if we're talking numbers, but it also needs to translate to incidence. I know whether it's official or unofficial, I think Botswana we're talking 95, something up there. And HIV incidence likely still remains high. And for Botswana, we really need to focus on the first two 90s for continued improvement. And as such, focus on the subpopulations, such as men who may not be unaware of their status. Just to acknowledge that for BCPP, it is really a two-protocol. This was just reporting on the first protocol for the household survey, and to acknowledge our partners, the Harvard School of Public Health, CDC, and the Ministry of Health, of course, sponsored also through CDC. Thank you.